continue with the lecture 6. So we will start about something is called Levy-Jennings plotting or plots. The Levy-Jennings plots, as you can see here, is the analysis of a quality control sample, and we said that the quality control sample, like we just control this sample, we analyze it multiple times for weeks and months, for to ensure that this will give us reproducible results. So we have here it's actually these plots, what we call them as Levy-Jennings plots. That's in an analysis of equality controlled samples compared to the expected value or acceptable values. So we just make a comparison between this control sample and we analyze it, and we just compare it to the expected values, the values that we really want to. So that is exactly the Levy-Jennings plotting. So the Levy-Jennings plotting is the analysis of the quality control sample and compare it to the expected or acceptable values. And you can see here that's what we call why we called it as a plotting. And there is something is called internal quality assurance. It's documentation of the daily control analysis. That we do this analysis of this control sample daily for weeks and months. Every day we make documentation, and that's exactly what we called it as the internal quality assurance. We just documented everything daily. Bias is a present reflecting the differences between the measured value and the true value, like how that is deviated from the true value. Just we make the bias, it just show us or reflect us the differences between what we measure and what is a true value. For example, the target value is 50, what we measure is the 45, so the bias is 50 minus 45, it will be 5, then 5, this is the true, like this is the difference, and then this is the true value. So the difference divided by the true value multiplied by 100, and this is actually the bias percentage. So we just divide what is the difference divided by the accurate value multiply 100. Ensuring accuracy, it's a desirable goal for the accuracy, like imprecise or bias, and that is causes biological variation. So what is a biological variation? The natural fluctuation of the analyte within an individual over the time. Sometimes the percentage or the value of the analyte, it will be not constant, it will changes over the time, and that's exactly what we call them as a biological variation. So that the fluctuations in the value of this analyte during the time. So there is called something is called total error allowable. Total error allowable equals bias plus 2 multiply CV coefficient of variation. That's exactly what we measure it by, the total error allowable. So the total error allowable equals, we can say it's a total error allowable, which is equals the bias plus 2 multiply coefficient of the variations. Now we talk like all this stuff that is related to the errors, how to control the samples, and this thing that is important for the sampling measurements. Then we go to the liver. The liver, these are multiple liver markers, and actually here, if there is injury to the hepatocyte, to the liver cells, when there is an injury to the liver cells, so that this causes the elevations of the AST, ALT, GGT, HDL, LDH, LDH also. So I'm just considering why the AST and ALT an increasing in the liver cell injury that we will discuss it later, but actually they are present inside the cell, so that's why it's an increasing when injury they're pressed, and then the AST and the ALT they all go outside, so that is an increasing their level. What I know about the GGT, that is membrane bound enzyme that is bound to the pillary system, but also I can say that is an increase in the alcoholic patient, it an increase if there is injury to the hepatopillary system, but not specifically to the liver cells. Lactate dehydrogenase, we have said that the lactate hydrogenase isoenzyme 5 that is present in the liver, so it will be an increase in the liver cell injury. About the fibrosis, we can see it by the histology, because the only method that we can see it just by the microscope histology, and we see the fibrosis. This is what we can determine if there is a fibrosis or not. Excretion, that's so important. In the case of the excretion, if there is problem in the excretion, so we just look about the alkaline phosphatase, GGT, and also bilirubin. That's why the AP and the GGT, they are membrane bound pillary system, so that's why they are increased in the case of the excretions, also the bilirubin. And then about the metabolic insufficiency, so there are multiples analytes that they are increased in the metabolic insufficiency, vitamin K, albumin, and choline esterase. Why they are just increasing or decreasing? Because that depends on the liver, because the liver that is create the vitamin K, so when there is a liver injury, that decrease the vitamin K and decrease the albumin, and also decrease something which is non-choline esterase enzyme. And maybe I will talk somehow about the albumin, some information about the albumin, which is affected here in the metabolic reaction, and in the case of the detoxification, ammonium and bilirubin increases. That's maybe explained, we can say, why the detoxification, because it's important to get rid of the ammonium, and that is happening through the liver. So when there is a problem in the liver, that will increase the ammonium, and that maybe causes cerebral edema and other stuff. So that is can maybe happen in the detoxification. So when I just make some explanations about the albumin, so we have the plasma proteins I discussed before, that we have the albumin, globulin, and fibrinogen. I said just before that the plasma proteins composed of the albumin and the globulin, but that actually it's composed of albumin, globulin, and fibrinogen. The most abundant protein is the albumin, which is a 50%, and then the globulin 38%, fibrinogen it's 4%, and then the globulin it's subdivided into alpha 1, alpha 2, beta, and gamma. And we know that the gamma globulins, that they are the antibodies, and alpha 1, alpha 2, that they are responsible, and also beta, they are responsible for the transport and the vitamins. And do you remember who is the beta 2 globulin? Actually it's the haptoglobin, which is decreased in the intravascular hemolysis. And then about the albumin, is actually come from the albuus, and the albuus, that's mean it's a white, like a white part of the eggs. And again, that is the major part of the plasma protein. It's about 58%. It's composed of the one polypeptide chain, because it's a protein already, but it's one polypeptide chains of 585 amino acids with a 17 disulfide bond. Imagine. So it's composed of a one polypeptide chain with a 585 amino acids with a 17 disulfide bonds. And if you're just talking about the molecular weight, it's about 69,000 Daltons. The pH of it is 47, and it's precipitated by the ammonium sulfate. It's a low molecular weight protein. It's most abundant, but it's low molecular weight, so it can be easily appear in the urine and the kidney disease, because it's low molecular, so it's easily excreted in the kidney and the urine. It is synthesized by the liver, so estimate the albumin is liver function test. That's what explain our why there is a metabolic insufficiency, so that is decrease the albumin level, because it synthesizes through the liver. And about the half time of the albumin is at 20 days. That's mean after 20 days they will be dead and then create another albumin. Albumin is present also in the CSF and the interstitial fluid. And what is the functions of the albumin that is responsible for osmotic pressure? So it's decrease of the albumin that is lead to the edema, and it's important for transporting, because you know that the bilirubin conjugated, because it unconjugated bilirubin, then it's bind to the albumin and then it will transfer to the liver. So the albumin is important for the transferring. And the free fatty acid, bilirubin, steroid hormones, calcium chloride, and other drugs. So this is so important also for the nutritive functions. Its degeneration provided a lot of amino acids, because we said that is composed of 585 amino acids. It's important also for the buffering functions. What is the method of estimating of the albumin in the blood is called BCG, which is known as promocresol green. This is the best method to detect the albumin in our sample. About the clinical significance, the hypoalbuminemia, when it's less than 2 grams per deciliters, and the causes maybe some problem that is happening in the liver, like a chronic liver diseases, malnutrition, malabsorption, or there will be abnormal distribution like severe burn, edema, and ascites, or overhydrations and the excess losses like in a nephrotic syndrome, and the protein losing into your bodies and hemorrhage. So all these stuff can lead to something is called hypoalbuminemia. So return back to the liver. So we have two enzymes. They are called ALT and AST, and the enzyme calcifications of these enzymes actually is two. So they are enzyme calcification two because the transferases just they are transfer the amino acid from one compartment to another. Let's focus about the AST. So if I'm talking about the AST that is present, both of them that are present in the hepatocyte, but actually the AST 80% present in the mitochondria. Just remember this information because it's important for many cycles. 80%, most of the AST that is present in the mitochondria of the hepatocyte, and 20% in the cytosol, while the ALT is the opposite, most of it that is present in the systole of the cells. Again, AST, most of it that is present in the mitochondria of the hepatocytes. Now we talk about the half-life. Half-life of the AST is 17 hours, while the half-time of the ALT it's about the 47 hours. So AST 17 hours, ALT 47, so it's a long time. So the AST just after 70 hours it will be dead, and then another AST will be formed, and the ALT it's after the 47. Then we go to something is called the D-Retis ratio, which AST divided by the ALT. So if it's more than one, what's that indicate? That's mean the AST, okay, it's larger than the ALT, and that is indicate the severe form of the liver, like alcoholic cirrhosis, like liver congestion, metastatic tumor of the liver. So that is an increased damage of the liver. If they both increase, because another name of ASTGOT, okay, these are the old names of it: hepatitis, alcoholism, and also liver metastasis. But really I want to add something to here, that if there is a increased alcohol consumption, so this alcohol that is lead to the damage of the mitochondria of the hepatocytes, especially the mitochondria, and that is lead to release of more of the AST, so that is increasing the AST. So it's a strong indicator of alcohol consumptions or alcohol overuse by estimating the D-Retis ratio, which just comparison between AST and ALT, which is more 10 times than the ALT. Um, that's all about the D-Retis ratio. about the glutamate dehydrogenase enzyme, which is so important, which is known as a glutamate dehydrogenase enzyme. It's one of the enzymes that increased also if there is a damage to the hepatocytes. And we said that the mitochondrial enzyme that is especially in the hepatocytes, so there may be something so similar to the AST, because AST also mitochondrial enzyme that is present in the hepatocytes, and also glutamate dehydrogenase. AST, the half time of it 17 hours, and this one is also the half time is 17 hours, more concentrated in the central areas of the liver lobules than in the peripheral, and that prolonged release of the glutamate dehydrogenase enzyme due to the centrolobular necrosis. Because every information means something, when I said the glutamate dehydrogenase enzyme, that the main area of it is the central of the liver lobules, that just give us a hint that if there is a necrosis in the centrolobular necrosis, that's been increased the release of the glutamate dehydrogenase enzyme. Another questions about the glutamate dehydrogenase, we said dehydrogenase. So what is the calcification of this enzyme? One, because it's oxidase reductase dehydrogenase enzyme. So we we have find that the glutamate dehydrogenase enzyme actually that is present in the central of the liver lobules. So when there is a centrolobular necrosis, that increase the level of the glutamate dehydrogenase enzyme. So there is an increase of the glutamate dehydrogenase enzyme, that will be an increase in the following conditions, like a severe hepatocellular damage and septic toxic circularity failure. So severe damage, that's mean it will arrive the central areas of the liver, and that is lead to something is called or increase the level of a glutamate dehydrogenase enzyme, but it has nothing done by the viral hepatitis, so there is no associated between the glutamate dehydrogenase enzyme and also the viral hepatitis. Now we talk about the half time of these enzymes, like GOTAST 17, glutamate dehydrogenase 17, CK creatine kinase is 15, while the ALT, which is takes longer time, which is a 47 hours. And then we go to the choline esterase enzyme. Actually, it's not all the choline esterase enzymes, pseudo choline esterase. No, not all of them. They are pseudo. Actually, it's subdivided into two types. Choline esterase subdivided into two types: true choline esterase and the pseudo choline esterase. Acetylcholine esterase is a breakdown the acetylcholine, so the acetylcholine formed in the soma of the neuron, and then it is stored in the clear vesicles and then released by the action potential, so the calcium influx by exocytosis, so that is will relate to the acetylcholine, and by the action of our enzyme here, choline esterase, then is lead to the destructions of the acetylcholine. So we have actually the choline esterase, we have multiple types of it. True, that is present in the RPCs, that is present in the choline nerve fibers, but not in the serum. But the choline esterase, our choline esterase, that is present in the plasma, and that's what we are talking here, the pseudocholine esterase. The pseudocholine esterase, this is the only one, because the true one that is present in the nerve, that is present also on the RBCs, but actually I'm talking here about the choline esterase that is present in the plasma, which is always pseudocholine esterase, and it's secreted by the liver and is a sensitive indicator of the liver synthesis capacity. The half time of 18 days, not our 10 days, it just long stay of choline esterase. It's indicator of the possible poisoning of the organic phosphorus compounds like parathorn and the serine, detect of a prolonged response to the certain muscle relaxants used in the surgical procedures. What we have to know about the choline esterase, actually the choline esterase, its function is just to destroy the acetylcholine, But the choline esterase is subdivided into two types. We have actually true choline esterase and the pseudo choline esterase. The true one that is present in the RBCs and the nerves, but for the pseudo one that is present in the plasma and it's synthesized by the liver. It's a good indicator of how the synthesis capacity of the liver, how the function of the synthesis in the liver, and about the half time of it, it's about 10 days, and it's a good indicator of these persons poisoned by organic phosphate compounds like parathion and serine, and show us if there is something wrong with it, so we can use the choline esterase, pseudo choline esterase, and also detect of a prolonged response to the certain muscle relaxants used in the surgical procedures. Then we go to the lactate dehydrogenase, and again dehydrogenase, so the calcifications of it is 1. And we said before that the lactate dehydrogenase is reversible, causes reversible reaction. So we have lactate plus NAD positive, so that is lead to the pyruvate, and NADH plus H positive. So the NADH is always with the pyruvate, and that is a produce energy, but actually it's the reverse reaction. And then the gamma glutamyl transferase originated from the hepatopillary, because we said that is a membrane bound enzyme. And yeah, exactly, that is present in the cancular membrane of the hepatocytes and the epithelial cells of the membrane canculi. That's why we said that is present in the hepatopillary, everything in the membrane. So we can say that is present in the membrane of the hepatocytes and also present in the epithelial cells of the pillary system. Gamma glutamyl is high organ specificity but low disease specificity. That's mean the gamma glutamyl transferase, when it's increased, it says to us that it's come from the liver, but I can actually don't know which disease, okay, of the liver happened. So the gamma glutamyl transferase is a high specificity, high organ specificity, but low sensitivity about the disease. Alkaline phosphatase is associated, we also discussed about that, and we said that the alkaline phosphatase is associated with the two function, lipid transport in the intestine and also bone metabolism in the bone. So the calcification process of the bone, so it's associated with the two separate functions. The first one is lipid transport in the intestine, and the other one is the calcification process of the bone. It exists in the multiple forms because it contains maybe 6 isoenzymes. We have discussed that before, and it's come originally from two sources, which they are the liver and the bone. So it increases in the cholestasis, and then increases also in any bone disease. And we said before also the cofactors of alkaline phosphatase is zinc and magnesium. So zinc and magnesium are the best cofactors for the alkaline phosphatase enzyme. And here we have the bilirubin, which is subdivided into the conjugated and non-conjugated. So we have the conjugated, which is a water soluble, and non-conjugated as not water soluble. So it's first synthesized as a non-conjugated, and then transferred by the albumin, and then will be transferred inside the liver, then will be conjugated and will become in the water as a water soluble, and then it transferred to the biliary system. Albumin bound bilirubin is not excreted by the kidney, because albumin bound bilirubin, it is still unconjugated, but just transferred, because it just all these synthesis, how, because it's unconjugated bilirubin, it's formed inside the spleen, and then the albumin transferred this bilirubin to the liver, just like a transport. It has no actions with the kidney. Albumin is a transport of the RPCs to the spleen to produce unconjugated bilirubin. And there is something is called the glucuronidation, has 20-fold reverse capacity. And when I said icterus is more than 2 milligram per deciliter of total bilirubin. We discussed before also the total bilirubin, but we have said that if it's less or equals to 20 micromoles per liter, we said that it's normal. But if it's more than 34 micromoles per liter, then that will be lead to the increased level of the bilirubin. More than 100, then it will be icterus. Okay, but that is another unit. If we just said it's more than 2 milligram per deciliters, that means the patient has icterus, which is a yellowish coloration of the sclera and the skin and the other thing. But you know, the first thing is sclera. And as you can see here, that is exactly what happened inside the macrophages. So it's heme and then heme oxygenase that is lead to the biliverdin, the biliverdin reductase enzyme, so that is lead to the bilirubin. Okay, and then it will go to the pillary duct. It's unconjugated and it will be transferred through the albumin, and then go to the bile duct, sorry, and that is glucuronic acid removed by the bacteria because it contains glucuronic acid, and that is lead to the pyrinogen and the stericopylinogen, and then it's called to the enterohepatic circulation. But the stericopylin, that it will be go to the stool, uropylinogen, it may be transferred to the enterohepatic circulation and maybe go to the kidney. Okay, but I will okay, I know that is not that easy one, but just idea about the whole operation, but I will discuss it in the very detailed form because I think that's so important to discuss this thing about the bilirubin, because an important topic to understand how the bilirubin form, because I think that is so important topic. And as you can see here, we can say that this can be happen in the macrophages, or we can say that can maybe happen in the spleen. So heme, by the heme oxygenase enzyme that is lead to the biliverdin reductase enzyme that is lead to the bilirubin, and then transferred by the albumin, so that is will be unconjugated bilirubin, and then it's go to the liver. Okay, sometimes that is leaded to formation of stericopylinogen and uropylinogen. Stericopylin, that is gives the brownish coloration of the stool. Uropylinogen, then it will go to the kidney and it will be excreted through the kidney. Prehepatic icterus, it's increase the total bilirubin and especially the indirect bilirubin, and I find that is logic because there is no problem in the liver. The problem is the maybe transfer of the bilirubin to the liver, because it will start to the spleen and the macrophages. So logically, indirect bilirubin, it will be an increase, and consequently the total bilirubin is also an increase. There is no bilirubin in the urine, and that's also, we can say it's logic also because to uropylinogen or stericopylinogen, actually they are formed after the conjugated bilirubin. So if it's indirect bilirubin, so there is no uropylinogen nor stericopylinogen at all. In the intrahepatic, direct bilirubin increase. So if it's an increase, then the bilirubin, it will appear in the urine. Posthepatic, that's an increase. The total bilirubin, direct bilirubin will appear in the urine. And also that is an increased alkaline phosphatase, GGT, and the pale colored faces. If we just explain that in more details, you will understand why all this stuff increases. And but I will just in modified or in the separate video, I will explain everything in details. So we have also the modified genderic group, and we want to know what is a modified genderic group. It's a total bilirubin assay. The modified genderic group is actually used to measure the bilirubin, to measure the total bilirubin. And inside it, we just said that the caffeine and the sodium benzoate are helping this reaction. So we use the caffeine and we use the sodium benzoate in this reaction. They help the release of the unconjugated bilirubin from its bond of the albumin, allowing accurate measurement. Okay, so what is a modified Chandrasekhar groove? The modified Chandrasekhar groove is to measure the total bilirubin, or we can say the total bilirubin assay. And we know that the unconjugated bilirubin, it binds to the albumin to be able to transfer to the liver. So we add the caffeine and the sodium benzoate. Why we add this caffeine and the sodium benzoate? Actually, we add the caffeine and the sodium benzoate to separate unconjugated bilirubin from the albumin, so it leads to the accurate measurements. And then we discuss the analysis of the bilirubin. So about the neonates, the presence of the unconjugated bilirubin. Why unconjugated bilirubin? There is an increased level of the unconjugated because for sure there is a problem in the liver. So if immature liver function, that is lead to increase the level of the unconjugated bilirubin, so that child it will be appears jaundice. I can't say a child, it's a neonate actually. So we use the direct spectrophotometer to measure the total bilirubin, only unconjugated, because we want to know what is the problem with this liver. And what's so important about these conditions, okay, about this unconjugated filter after correction of the oxyhemoglobin, because unconjugated bilirubin and oxyhemoglobin, they have the both absorbs light and maybe they have the same range, because we said before that the bilirubin, the range of it is 400 to the 540, while the hemoglobin, and we said oxyhemoglobin, that is present in the neonate, the absorption it is just from the 500, I think, to 540, because it has many ranges, so they are just, they have the same range for the absorptions of the light. So my question is, what is the problem? Why oxyhemoglobin? Then where we can so measure it? Because we know that the infants and the neonate, they have a high level of the oxyhemoglobin. So most of the neonates, they are just come with the jaundice because it contains a high level of unconjugated bilirubin because of immature liver function test, and we just make sure to measure what is going on with the unconjugated bilirubin to know if that is a normal condition or what. Then we should use a spectrophotometer, but we have to clear it from the oxyhemoglobin, because the unconjugated bilirubin and oxyhemoglobin, they absorb the light. And something is called reflectance photometry. That's what we use it here, which shine the light to the skin and measure the reflected light back. It measures a transcutaneous, which is invasive and not painful. So we just looking for something that we can measure the light without causes anything to the neonates. Maybe the mother or the family say they just want all the pinches and this stuff to the neonates, so we measure it by something is called reflectance photometry. We just expose the light to the skin of the neonate, and then some light is reflected, so we measure this reflected lights, so it's not invasive, it's a transcutaneous and not painful. And about the high performance liquid chromatography, this high performance liquid chromatography, it's a lab technique that is used to separate and analyze different types of the bilirubin in the blood sample. So it's distinguish between the conjugated and unconjugated bilirubin. So what's so important to know about the high performance liquid chromatography? H is high, P performance, L liquid, C chromatography. So high performance liquid chromatography, this lab technique that is used to separate and distinguish between the two types of the bilirubin, conjugated and unconjugated bilirubin. What is the enzymatic assay of the bilirubin oxidase enzyme? which is the bilirubin plus oxygen. Then we use bilirubin oxidase, and that is lead to the biliverdin plus H2O. And we discussed that in the macrophages of a spleen. We said bilirubin with the help of the enzyme bilirubin oxidase, that is will lead to the biliverdin, but that's more details. Like we bilirubin with the oxygen with the help of the bilirubin oxidase, that is lead to the formation of the biliverdin plus H2O. And then we will talk about the Greek-Niger syndrome. The Greek-Niger syndrome actually, it's due to an increase, or we can say isolated unconjugated bilirubin. So that's why we use the reflectance spectrophotometry, because sometimes it's normal that the neonate has jaundice in the first, not in the first few days, I mean in the first few days, but not the first day. But if it's the neonate have the jaundice from the first day, then that is pathological. But if it just from the second day, then we can say it's physiological. There are some reasons for that, but I'm just focus on the Greek-Niger syndrome. I'm just see this information because not all the jaundice are normal, so we have to do test. Greek-Niger syndrome, that is due to the isolated unconjugated bilirubin. And actually we have two types. The first one, that there is no enzyme at all, which is known as uridine diphosphate gluconosyl transferase enzyme. Again, we said U, that's mean uridine diphosphate gluconosyl transferase. And when I said transferase, so that the calcifications of it, what? It's a transferase, so the calcification is 2. So uridine diphosphate gluconosyl transferase enzyme, but we just 1A1. Some they don't say 1A1, and some they just more specific and said 1A1, but it's actually diphosphate uridine diphosphate gluconosyl transferase enzyme, that is turned the unconjugated to the conjugated, that is present in the liver. So when there is no at all of this enzyme, so it's a big problem. Type 1, it's more, it's lead to the death actually. So the best treatment is liver transplant, phototherapy, exchange transfusion, but actually the best treatment for it is liver transplant. Photometry, phototherapy, or exchange transfusion maybe it's not so helpful. Tab 2, it's reduce the action of uridine diphosphate glucosyl transferase 1A1. So we can treat the patient by the phenobarbital and the phototherapy also. So we can treat it by the phototherapy, and we can treat it also by the phenobarbital. We have Gilbert syndrome. We can say Gilbert syndrome as easily. It's also due to the unconjugated bilirubin, but also reduced form of the uridine diphosphate gluconosyl transferase enzyme. So there is a hope because they are reduced, but if there's no enzyme of it, so it's lethal, which is a type 1 of a Greek-Niger syndrome. Less severe, okay, but I mean type 1. And the enzyme helps to clear the drug from the body. It's so important. This enzyme is so important to really to remove all the toxic drugs from our body. Paracetamol is contraindicated if the person has Gilbert syndrome, so you can't at all give him paracetamol, which like a routine thing that we take it every day without any respect. But in the case of the patient that he know himself that is a Gilbert syndrome, so should the physician said to him, no paracetamol at all. And the question is why? Because it metabolized by this enzyme, pyridine diphosphate gluconosyl transferase enzyme. So you have a problem in this enzyme, and I said before, it's the enzyme is important for removing of a drug, so be careful with dealing with this drug. Cleared in the liver, so if it's not cleared, so it will accumulate in the liver, and it's the best toxic for the liver. Not the best, I mean the worst thing that it can be happen in the liver. So the paracetamol is contraindicated in the Gilbert syndrome. It's actually contraindicated if you have a problem with the uridine diphosphate glucosinyltransferase 1, because it metabolized by this enzyme, so that it will lead to accumulation of the paracetamol, so that maybe lead to toxic effects of the liver. So actually that was the last thing about the lecture 6. Actually I feel like this optimistic because some points like this growth that I talking about, it is modified gene-directed growth. I think that's is like not all the information. I hope you understand anything, and thank you so much for listening.